gamna sonida tan vin burlo oh gamna sonida tan vin burlo gamna sonida tan vin burodi na thaldi gadiyal erodi na thaldi gadiyal lamuda 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 lerraler ek tari betari ke ho koi par grown aaj tak karwa tumhare ghar pe power moon
Netflix on the screen, healthcare in between, physics, art, math, got us down this path. Historical tales come alive, where science and stories dive, blended facts with heart, knowledge from the start. Need bridge blues we sing to the future memory. Health and science in the mix, Maybrick's got the fix. Complex subjects made
right
clear,
now
every episode
in
with
ways
cheer.
that we actually acquire
Ramona
knowledge
leads the way,
and ways that
explaining
make
day
me
by
more
day.
efficient.
In the world of digital streams, turning knowledge into dreams. Through the tales of old, new stories unfold.
Thank you so much for joining with me. It is truly an honor and a privilege.
MedBix Webcast is a new kind of healthcare media channel to break the silo mentality and foster interdisciplinary thinking. Our mission is to fill that gap and to create a curiosity through different lenses, tapping the passion that guided the historical figures in medicine and bringing present-day groundbreaking research to the front lines. We interview physicians and leaders in the industry about present-day healthcare challenges on our live programming.
Hey, welcome to the MedBix Webcast. No, yeah. Welcome to the MedBix Webcast. This is Ramana Annam Raju. I'm the host. You know, that song is my favorite song of a Gujarati song. I don't understand the Gujarati language. That's where the Dr. Patel is from. So I love that song, you know. My son had also that language, that rhythm, so he loves it. So that's one of my favorite. That is like a festival song, I think. I don't know exactly, but that's a beautiful song. But anyway, Doc, I'm going to introduce my co-host now. She is a much better looking, better talking, and then she has a brilliant woman. She's a rescue RN founder. She's a doctor of nursing practice. She's a brilliant. And then let me bring her to the table. And then Dr. Susan Davis. Hello, Susan. Welcome.
Good
Welcome
evening.
Yeah,
Hello,
how are you?
hello to your audience. Thank you so very much for having me. I feel very grateful to be here with you. Thank you for the opportunity.
Yeah, so let me bring both of us together 1 second. That if we can, yeah, I got to take this one out. Yeah. Oh no. Oh, 1 second. These technical things are really
You told me
problem.
not to push any buttons.
They don't put any buttons. Yeah.
Yeah, you told me not to touch anything. I'm not
Yeah.
touching anything.
Okay. So now you're full-fledged. So you're safe right now. There are no hurricanes. You're not surviving. You're not drowning. Anything up there. You're safe. Right.
Safe and sound, ready to meet your amazing guest, Dr. Patel. Yep, who's also from Florida. So
Yeah.
I'm very thrilled. This is another amazing human. I don't know how you do it, Ramana. You bring on some of the most amazing minds that this world has to offer us humans. So I'm blessed to be here.
You have a lot of things in common. You're both in cardiology and hurricane. Both experience hurricanes, so that's good. So let me structural cardiology. I wanted to ask you, Susan. I'm not a cardiologist. I'm not a doctor. So structural cardiology. I know interventional cardiology. Actually, I met the upcoming guest, Dr. Nish Patel. I met him when he won the. We have an association called Indian Doctor Association, Indian Cardiology Association called American Association of Cardiologists of Indian origin. He won the investigator award a long time ago, maybe 10, 15 years ago. I met him when he doesn't have still gray hair, but he's still looking young. So he's still upcoming cardiologist, and he's a structural cardi. He's also did a fellowship in structural cardiology. At that time, we don't know the structural cardiology much. Everybody knows about interventional. They do stents, all those things, Susan. I come to know recently about structural cardiology. They specialize in field. They're doing a fellowship. Doctors are doing fellowship there. They do a lot of, the structure of the heart, like the walls, the valve replacement, and the walls of the heart itself, and the ventricles. The whole thing. So you can expand a little bit about that, and then we will bring Dr. Patel after that.
Yeah, well, I'm far from a cardiologist like our expert, Dr. Patel, this evening. What I can tell you again is, my one of my goals of being here co-hosting with you is to bring a little bit of a nursing perspective. And I can tell you a lot of my colleagues that work in the cath lab, I mean, that is a specialized space, and everybody in there, you got to be a rock star. I mean, they're going into those structures of the heart, and in so doing, it's very irritating and it causes problems while they're there, but they're expecting it. So I do some consulting and whatnot in the cath lab, but I can tell you right now, that is a world of their own. Responding to codes, they handle their own primarily. The equipment they use is so specialized. It's an area of massive amounts of expertise, and it's an area where I cannot wait to learn from our guest, Dr. Patel, about some of the. I mean, listen, if you have a heart, you qualify, and everything in that room is heart-centered, is including every single one of those team members who are there in it to win it for those patients. And I actually, Dr. Patel has a 103-year-old patient that he recently worked on. So I asked him about that.
That is amazing. We'll bring him. Structural cardiology, actually, what it is, I think open heart surgery. I used to remember when I was a kid, it's a big deal. Now is everything. Let me bring him to the table. Hey, welcome, Dr. Patel. Dr. Patel, welcome to the MedBits webcast.
Hi, Raman. Hi, Susan. I'm happy to be here, and thanks for the warm introduction.
So tell us a little bit about your journey a little bit, where did you do your residency and fellowship, and what the structural fellowship? Can you just give us some background of yours a little bit?
Yeah, the reason why I still look slightly younger, even though we met almost 10 years ago for that, Indian origin cardiologist meeting and for the Young Investigator Award, is because, I started my residency at the age of 23. So as I was born and raised in India, in a city called Ahmedabad, only about 2 blocks away from Gandhi Ashram, where, Mahatma Gandhi spent last few years in Ahmedabad. And my med school was in Ahmedabad, Gujarat University. That's where I did my med school, and usually, you do med school right after the high school. So I started the med school at 17 and a half, and my family moved here to States when I was still in med school. And over there, if you do really well in your high school, you get a scholarship, you actually get into a government medical school, right? So I was only paying 6,000 rupees, which at that time was about $150. So I went back to finish my med school while my folks settled in upstate New York. There was a small town outside of Albany called Amsterdam. That's where my folks stayed for about 1 or 2 years, and then they moved into Albany. And while I was finishing my med school in India, and then after finishing my med school, I gave all those steps and things like that, and I started my residency at University of Oklahoma at the age of 23. And,
really? I went to Norman, Oklahoma. Actually, yeah. I'm a graduate of Norman, Oklahoma.
Yeah. So Oklahoma is a great memory from Oklahoma City.
It's a different world.
Yeah, and I did 4 years over there. I stayed there as a chief resident also. And then I moved to University of Miami because when I joined my residency, I in fact wanted to do a GI or pulmonary critical care. But, University of Oklahoma is known for its electrophysiology. In fact, the cardiologist, Warren Jackman, who actually, worked on WPW ablation, so the advanced ablation procedures came out from Oklahoma, which is fun fact about Oklahoma City in cardiology. And so I was inclined toward electrophysiology because that was huge in Oklahoma City. But along with that, I was also interested in heart failure. And I had my mentor, Dr. Bob Meyerberg and Udo Thadani. So they recommended me to go to Miami because in Miami they had a transplant program, and there was a good EP program, and that's why I landed up in University of Miami. And my first month of my cardiology fellowship was a cath lab rotation. And I just fell in love with the cath lab, the instant gratification that you get in the cath lab right after somebody coming into the cath lab with a heart attack, and just matter of half an hour to 45 minutes, we changed that person's trajectory. Was so fascinating to me, so that I decided to pursue interventional cardiology. And during that rotation, I always used to watch the live case videos of Mount Sinai. So Mount Sinai Hospital in Manhattan is the highest volume cath lab in the country. It's led by Dr. Samin Sharma and Dr. Kinney. And that's when I decided that I want to do interventional cardiology over there. Around that time, this was 2014 to 17. That's when I did my cardiology fellowship. And TAVR was FDA approved in 2011 for the high-risk patient population. High risk is basically those who are really high risk for surgical aortic valve replacement. When the STS score is one of the score that you measure, which determines that what's the risk of that patient's surgery, of dying during the surgery. If that's more than 8%, we call it a high risk. So
how do they measure that, doctor?
It measures. It takes a lot of patients. What's their age? What's their gender? What are the comorbidities that they have? If they have a lung disease, what's their heart functions? If they have blockages in the heart arteries, also what's their WBC count? What's their kidney function? All those data you put in that database called STS database, and it gives you score. And if it is more than 8%, we call it a high risk. So it was approved for those patient population, and the trials were ongoing for the intermediate risk patient population, which is STS score between 4 to 8%, and the low risk is less than 4%. So that was amazing that you do a valve replacement without even opening a chest. And patient usually at that time used to go home in about 48 hours or so. I got
almost like outpatient procedure it became, right? It's a really revolutionary.
Not outpatient; it's still inpatient. The code is inpatient. The patient always gets admitted, but it's almost kind of an elective. I wouldn't be surprised in the next decade if we say that the patient. I just had my dad having a knee replacement. We went to the ambulatory surgery center. He went in to the OR at 7:30, got done around 8:30, and he was home at 12. So I won't be surprised if in the future the TAVR follows the same path. That's when I decided that I want to do structure. And along with that, the mitral therapies were also coming in the horizon, where the mitral valve repair can also be done by the catheter-based approach. So from there, Miami, I went to Mount Sinai to do my interventional and structural heart disease fellowship, and I stayed there for about 2 years. And when I graduated, 2019, June, I finished all my training, and then November, we have a big meeting called TCT, Transcatheter Cardiac Intervention Therapeutic meeting. It's a big meeting in interventional cardiology space, and the two trials were being presented at that time. One was a low-risk trial, and the low-risk TAVR trial, which was TAVR procedure in patients who are low surgical risk patient, and the other trial was a COAP trial, which was a trial about the mitral valve therapies, catheter-based mitral valve therapies called MitraClip by Abbott in patients who have a leaky mitral valve with a heart failure, which was a really big trials that actually led the path of significant growth of structural heart procedures. The 2019 year when those trials were published. So it was a perfect time when I started my practice when both of these trials were coming out with positive data, and 2019 probably was the year when the TAVR procedure overtook the surgical aortic valve replacement. So when you look at all aortic valve replacement and you divide them, how many did this get the surgery and how many got the transcatheter valve replacement, around 2019 or 2020 was the year when TAVR sort of crossed the SAVR procedures.
Dr. Patel, how do you do? Tell me the rundown of the case to some extent. Just particularly transcatheter patient. How do you do that? The process in the morning when you get that patient, suppose in your office, and how do you determine and what do you do with them? How do you prepare? And
so let me have a step back and tell you what the procedure is being done for, right?
Yes.
So TAVR for the audience is transcatheter aortic valve replacement. And that procedure is done for the condition called aortic stenosis, right? So aortic stenosis is a condition where you have your aortic valve, the valve located between the left ventricle and the aorta, a major valve because it's a gateway for the blood to go from the heart to the rest of the body. As you age, you tend to have wear and tear of that valve, and you have a calcium buildup where there's a wear and tear. And incidence of this aortic stenosis is about 1% after 65 years of age. So if you look at the whole United States population, 1% of 65 years and above would have this. After 75 years, that incidence goes to 3%, and after 85, it goes to 10%. So as you age, you tend to have this aortic stenosis. And it's not benign conditions. Once you have severe aortic stenosis is when your aortic valve area is less than 1 centimeter square. Normal valve area is about 2 or more. So what in layman language that means is when your valve opening is less than half of what it should be. That means that the left ventricle or the pump has to work double to send the same amount of blood across that aortic valve. So usually patient would get symptoms of fatigue, tiredness, difficulty breathing. If left untreated, they may get chest pain. They may get heart failure symptoms with the swelling in the leg, difficulty breathing, doing minimal activity. They get short of breath. And in very severe cases, you may get syncopal episode where you pass out. And if left untreated, once they have symptoms, the mortality, chances of dying is about 50% at 2 years. So this is the number sort of similar to somebody having a stage 4 breast cancer or lung cancer, right? But we don't take, in general population, people don't talk about aortic stenosis as being a major issue that needs to be addressed rapidly.
50%, my gosh.
Exactly.
Wow.
So, that's why there are, discussion about changing the terminology and calling it a heart valve failure or something like that, so that, the general population would understand the critical issue of this disease. And so TAVR procedure is basically a treatment of that. Now, when you have that aortic stenosis, severe aortic stenosis, and
are you putting the mechanical valve or what? You're replacing the valve, right? Basically,
I'll get to you.
Yeah.
So there are two ways you can fix it. One is surgery, which is open heart surgery, and the other one is a transcatheter option. So in the open heart surgery, you can do it by different way. One is you can put a mechanical valve, which is, that's when you hear the clicks, right? Those discs are opening and closing, and you can hear a click from it. And that's only preserved for the younger patient population, those who are less than 50 years of age. That's where we potentially would think about mechanical valve, because the other approach in the surgery is putting a biprosthetic valve, where they put a tissue valve, which is a cow tissue or a pig tissue, a bovine or a porcine tissue.
Dr. Patel, are they getting? Is there any talk of creating those valves? Are we going to put them in the 3D printers and make some human tissue valves? Is that in the future?
Good question. So right now there is some research going on about having a synthetic material and making a valve out from synthetic material, which is not a tissue, not a bovine or a porcine tissue, but sort of a new man-made tissue. And the research is to make sure that how can we make sure that this whatever we are using would last longer than 10 years. Because usually the bioprosthetic tissue, the durability of the valve, how long the valve is going to last, it's about 10 years or so, right? So that's why in the younger patient, less than 50 years of age, we think about mechanical valve, because, if we think that 50 years, and I think,
are there any complications? Are there any complications with a mechanical valve, like an infection, anything like that, Dr. Patel?
An infection, but with the mechanical valve, you have to take a blood thinner for a lifelong, right? You need to be on a Coumadin, the rat poison, for lifelong. That's the cons of that procedure. The infection and all that, obviously, if you have a diabetic foot or any other infection, the risk of having your valve infected going to be higher, but that's going to be the same with even biprosthetic valve. It's not only to the mechanical valve. With the mechanical valve, you have to worry about the clot formation on that mechanical disc, because if your blood level is not in the proper range, then you can have a clot formation. So you have to be very punctual about taking your blood thinner.
Don't both patients have to take the blood thinners, Dr. Patel?
No.
Only the okay.
Only the mechanical. The bioprosthetic patient, they only have to take the baby aspirin.
Okay.
You might choose to give blood thinner in the first 3 months, but not for the rest of the life.
But Dr. Patel, the question is, people who are putting on the aspirin, for example, I used to do the genetic testing on the PVC 19, that is a Plavix. I used to do the test. We used to offer the test. So is a bigger issue there for particularly patients of foreign patients like Indians and Asians?
No, it's not. That's probably for the stent, but not for the valve.
Okay, that's very good.
So, and then the TAVR procedure is basically doing the same bioprosthetic valve, but doing it by the catheter-based approach. So the first company which actually did this was Edwards Life Science, and their valve is called Sapien valve. The other companies which also have FDA-approved valve is the Medtronic, which have Evolute, and the Abbott has the valve called Navitor. So those three valves are currently available in the United States. And they also have two separation. One is the balloon expandable valve, and the other one is called self-expanding valve. So balloon expandable valve is the valve which is basically a stent, and within the stent there's a valve sewed in, and within the valve there's a balloon, and all of them are crimped together on a catheter. And we basically go all the way to that stenosed valve, aortic valve, and then blow up a balloon and essentially deploy a stent, and then we deflate the balloon and take the balloon out, and now you have a new valve. Here, the important distinction between the surgical valve replacement and the TAVR is, the TAVR, we don't take the patient's native valve. It's basically compressed within the patient's anatomy.
Interesting.
So we essentially push that disease valve with the stent, and it just stays there in the sinuses of the aorta. And that has some implication in the sense that it can cause some thrombus formation there's some data coming out that there may be some leaflet thrombus because of that, but it's still in the research phase. But in overall, what we know from now is the TAVR is similar to surgical aortic valve replacement in terms of the durability so far, up to 5 years. And there are some data up to 8 years. And the major advantage of the transcatheter aortic valve replacement is, let's say, when the patient has aortic stenosis, if they come to see me and we think that patient is suitable candidate for transcatheter aortic valve replacement, what we would do is we would have this patient first get the CAT scan of the chest, abdomen, and pelvis, because the most important part of this procedure is the planning of the procedure. 70% of this procedure is essentially a planning, and 30% is the execution of the plan. And the planning involves the CAT scan, which
Why do you need a pelvic CT CAT scan, Dr. Patel?
chest, abdomen, pelvis, because we go through the groin, through the femoral artery. So, we have to understand the anatomy of the femoral, the iliac arteries at the aorta to make sure that it's suitable that we can go from the femoral artery.
Yeah.
If not, if there's any other alternative route that we can use.
Dr.
And
Patel, do you also routinely use sonography?
yeah, sonography, echocardiogram is mainly used for the diagnosis. Previously, early on, when the procedure came and it was in its infancy, at that time we used to do TE also, transesophageal echocardiogram, for further evaluation. But now there's no need for that once we do the CAT scan. And then we also do a cardiac catheterization to make sure that they don't have any blockages in the heart artery. So we would do an angiogram through the wrist and right heart catheterization. And then based on that CT, we actually do the whole procedure virtually to see if there's any issues. We would size the valve, because there are different sizes of the valve. We have to make sure that there's no major risk factor based on this CT. And we would also choose the appropriate size and which valve that we have to put. And then patient comes on the day of the procedure. So on the day of the procedure, they would come in the morning. Let's say if they have a 7:30 procedure, they would come at 6 o'clock in the morning. They'll get prepped in the pre-op area. They'll have IV line placed, and we'll get consent. We'll speak to the patient, the family, and
Hold on, Dr. Patel. Your interesting thing you're saying, you're coming to my world. You're doing a digital, you're saying simulation program. You're doing a simulation on the digital computer, or that the whole planning and everything, and including the administration of the catheter going the process?
Oh no, not that. Not that. The procedure, in the sense that when we put the valve, that we can put it on the CT scan, right? So that simulation, the virtual.
Yeah, but that's still
not
That was the
the
virtual part. That was the virtual part, right?
Exactly.
Referred to. Okay.
yeah, that's
Exactly. And then a patient would go into the room. Based on that planning, we would just execute the plan, that 30% of the execution. And the most important complication of this procedure is the heart block and requirement of the pacemaker, because the electrical tissue of the heart, the AV node, just sits right underneath the valve. So you can have the heart block. That's the main complication of this procedure. So we would make sure that if the patient is high risk for the pacemaker or not after a procedure in the lab, and then after the procedure, they'll come out in the recovery area, get recovered for about 2 to 4 hours, would walk after the procedure, and then they'll go to the room, the telemetry floor, and would get monitored overnight to make sure that they didn't have any other issues in terms of the heart block or high risk for heart block issues, and they didn't have any bleeding complication. Usually they go home the next day. So that's usually the patient's journey. And we see them in the office in 7 days to make sure the procedure went well, they don't have any issues, and then we see them again at 30 months and 1 year as a part of the procedure. They obviously would see their own cardiologist as scheduled 3 months, 6 months, however they are seeing their cardiologist.
What a gift.
Fascinating.
What a gift.
Let me. This is you're saying that the patients come there. I used to watch Dr. Naveen Nanda doing a mitral valve prolapse, and then on the cardiac echocardiography, I used to watch that with him at the time. Let me ask you. Now you can do valve replacement. All the valve replacements you can do, repair the valves. What about the valves of the heart itself? If they have vegetation, or if there's infection, or if the beacon muscle of the heart, the wall itself. How do you what you only transplant, or you have any other options you can do?
Yeah, so the very good question. So infection, I can talk about it. We just recently did address the infection of the mitral valve and the aortic valve also. So for the infection, previously the only option was the open heart surgery, and there's still many cases the only option is the open heart surgery, because if there's something infected, you don't want to put something, right?
Yeah.
You want to take out all the infection. So the catheter-based valve replacement and repair is not for somebody who has active infection, right? If they have active infection, and if you put a valve in that, the patient's going to have the infection of that new valve also. But if they have
We're talking about two different populations here.
Exactly.
It would be the high risk rather than the low risk patient. So
yeah,
right.
and
So
high risk, low risk doesn't matter here, in the sense that once they have infection, active infection, ideally the treatment is the antibiotic and removal of all that infected tissue, and sometimes they have abscess also.
I guess I'm thinking that's what would make them high risk, thinking of that infection in those valves.
Exactly, and sometimes they are so high risk that the surgeon would also not be able to do anything. Right. So in that situation, what you do, and sometimes they have a big vegetation. Vegetation is that infected tissue sticking on that the valve, which is just moving around and can break, go to your brain and give you a septic emboli and infection into the brain and things like that. So there are some devices which is usually used for PE, the pulmonary embolism, where they have a clot in the lung artery, where you can suck the clot out, such as Inari, Penumbra, Angiovac. These are some of the devices used for thrombectomy that can be used as an off-label device to suck the vegetation out. So we had similar case where a patient had the vegetation of the transcatheter heart valve, and extremely high risk for surgery. So we actually use a Penumbra device and suck the vegetation out. And one of the other patient had the vegetation of the native mitral valve and very high risk. So in that situation, we actually did a use device called Angiovac and suck that vegetation out. So you can use some innovative solutions, which is being used for the other domain.
Interesting, very interesting. So you're talking about the vegetation part. What about if the muscle dies, the wall of the part of the muscle? I'm asking I'm not a cardiologist.
Like post MI, you've got
So, but what you're talking about is the myocardial infarction. So, if it's acute, if you present in a timely manner, the treatment is obviously fixing the blockage, right? That's the myocardial infarction, the STEMI and non-STEMI. Yeah. You fix the blockage and put the stent. But a lot of patients, especially outside of US, in emerging countries like India, China, even Ethiopia, for sure, there are a lot of patients don't present in timely manner, and they don't have the STEMI network or the system in place to take care of these patients. So most of this patient would have dead muscle because they don't get fixed and the muscle dies down. The treatment of that is once the muscle dies down, there's nothing. I mean, the people are doing research about the stem cell, injecting the stem cell into the myocardium, but it hasn't panned out yet. We don't have any positive result.
Because transplant is the only option there at the time.
Yeah, eventually, if the heart function is extremely low, then the transplant, and if the patient is young and a good social support, transplant would be the only option at that point.
Maybe we'll get back to our 3D printer, and now instead of just valves, we're printing hearts.
Yeah, in the future, you never know what we could have. And I wouldn't be surprised in the future if we have a drug which can address the calcium, which would be the holy grail of the cardiology, because if you can prevent the calcification of the valve or the arteries, that would be huge. And I mean, there are some folks working on it, but that would be something. I know people take vitamin K2 and all that, but I don't know if it works. Theoretically, it works, but we don't have a population-based big data out there which can prevent the calcification.
Dr. Patel, your job is safe. Nobody can replace your job, but there is a lot of talk in the healthcare world. AI is going to replace the doctors. I'll tell you a little bit. I'm going to present why they cannot replace. There is some foundational problems are there. I'm going to talk about it for a few minutes, and then you can jump in.
Yeah,
So
sure.
that's Dr. Nish Patel from Miami, Florida. A very interesting topic. There is a billionaire, Vinod Khosla from, he's not far from here, where I'm right now, is a tech billionaire, Sun Microsystems. He was one of the founders of the Sun Microsystems. He said that 20 years ago, he said that we're going to replace all the doctors, the robots are going to take over. All the doctors are so upset at the time. I remember those days. Dr. Nanda said that he's talking nonsense. But now the reality is coming very close, in fact. But there is some problems there. He is not 100% right. There is a foundational limits on the limits of AI. I'm going to talk about it. There's 3 pioneers in computer science talking about it, about the foundations, limits on the AI. This is the first time we have a direct conflict with the science and technology. Technology follows science, but the science is telling something about technology that he cannot do that. This is a science, mathematics. So this is the first time what is science is telling us about the AI. Energy consumption is not normal. This is no way technology can meet that requirement of energy consumption of AIs. The second one is very strange concept. I'm going to explain to you in more detail. Self-contradiction. Self-contradictions are how we handle the self-contradiction. The third one is the most powerful one. These are all scientific. I'm not talking about any abstract. Intuition. That's where we excel. Humans, the doctors can excel. I tell you what those are all. His name is, this is Jan LeCun. He's a chief scientist at the AI at Meta. Meta is a chief AI scientist at Meta. He is a Turing Award winner. That's like a prestigious Nobel Prize in computer science. If you are using a GPS, you're using his technology. He is a very well known. He was saying that AI robotics have a limits. Energy consumption is a big problem, and the hardware is no way right now at this hardware that can match the requirement of the real understanding of the world and everything else. You need a new kind of physics. The requirement is new kind of physics required. We don't have it right now. So what he's saying is, for example, I'll give you energy consumption. Human brain, Dr. Patel can do rice and dal and he can do the heart surgery in the afternoon. But that's 20 watts. He can do a sandwich. He can do the heart surgery in the afternoon. The Susan can rescue people with just a small burger. But but that is, you need the same thing to AI to power that. By 2030, you need 1,000 terawatts of power consumption is expected. 1,000 terawatts, megawatts, gigawatts, terawatts on the top. It's just a huge amount requirement. Fort Myers, where she's from, Susan is from, is a 1 terawatt per year. 1 terawatt consumption they do. You need to create to address all the AI LLMs. You need 100 Fort Myers power required. Think about it. It's not possible. It's not easy. So this is the biggest requirement is the energy requirements because the heat is, and then environmental disaster, the heat it produces, and it is a really problem with the carbon footing and the environmental aspect. So there is a fundamental limit in the energy consumption. That is a bigger. We need to come up with some efficient models. We don't have it at this time. That is the one fundamental limitation on the energy consumption. It's not practical at this time to do that.
Job
Then
security, Dr. Patel, job security.
job security yeah, absolutely.
Sorry, Ramana.
No, you can jump in anytime, Dr. Patel.
No, I think who knows? That's why there's a lot of interest in the nuclear energy right now.
Yeah,
All the companies which are working on the nuclear energy, there's a lot of money going into it. And
I'm a nuclear physicist. Microsoft started a nuclear reactor there. And then, Oklahoma, University of Oklahoma, I used to work on the nuclear reactor there in the University of Oklahoma, Norman. We had a first reactor in the university. I was a student there, actually.
Even Sam Altman had
nuclear reactor.
His SPAC actually sponsored company Oklo, which mainly working on the nuclear energy.
But the nuclear energy has its own problems, right? Because it is another aspect of it. I'm going to tell you about the nuclear energy. So the second problem is the hardware itself. Neuromorphic computing means you have to simulate the neuron into the chip. It is not possible. I tell you why. The neuron mapping, actually the first neural network was invented by a doctor. Is a Warren McCall. In the 1940s, he came up with some mathematical. He's a mathematician, physician, he's a doctor, he's a mathematician, he's a philosopher, he's a poet. Actually, he's a polymath, true polymath. He created a father of the neural network. Actually, he's not a computer guy. He's a doctor who created it. Dr. Patel, inspiration for you. You can do that next time. So this is neurons you cannot, there is no way you can put in the chip. This hardware is not compatible. You need to come back with a new biophysics, new kind of a system. You need to come back. This chip is not possible. You cannot simulate neuron in the chip. That's a restriction. So also on the brain, we work on the analog system. We are a continuous system. In the chip is a digital 1 and 0 binary systems. So there is a big divide in that to make the chips into neurons. There is a neuromorphic computing is a fundamental limit on the process. The next one is the software problem. This guy, he put a spell on AI. I tell you, his name is Kurt Gödel. He's an Austrian physicist. 1940s, he came to Princeton. He studied with Albert Einstein. He's in New Jersey. I tell you, this guy, the mathematicians, hate him because he's a mathematician. What he did was, there will be just added a little bit of a flavor to it, but the concept is basically what he said indirectly. There will always be problems where AI cannot determine the truth, however sophisticated AI is. There will be some problems that AI cannot solve. It is a fundamental limit on the software. He came up with a mathematical framework. This guy they call him party buzz killer because all mathematicians are all having a great time. Everything is all logic and reason. He said that no, that is not possible. There is some statements you cannot test it. For example, contradictory statement. This statement is false. You cannot prove because it's going to the loop. And then I am a complex being with a simple purpose. That is a very strange. That kind of a statements in the computers can create a crash. It goes crazy. So I cannot solve some of the contradictory problems. For example, Dr. Patel can go with his grandmother and pray with the Cobra temple. He can go there and pray. It's illogical. It's kind of. Then in the afternoon, he can go and do the heart surgery. Humans can accommodate contradictions. We can live all this with the contradictions. Believe it. That is the power of the humans. belief and logic. But in the computer side, if we have a sufficient number of contradictions, it will crash. There is no way you can solve the problem. That's a bigger problem. Contradictions, that's what the Gödel was saying. Contradictions create a problem. That is a bigger. So actually, it is a theorem. It is called Alan Turing, the father of the modern computing, said that halting theorem. It says that implies that no AI, no matter how sophisticated it is, how advanced it is, can perfectly predict the outcome or behavior of every possible program. You cannot use a program to tell something is what is the outcome is. So that is a restriction on the computer. So the computers, the mathematical restriction is that Turing said that Alan Turing said you cannot predict the outcomes in advance. It could be dangerous sometimes. So that is for example, AI cannot predict Netflix. I give you a very low level example of that is Netflix binge watching people. They used to watch all the series, and then my mother used to get these serials in India. Every week there's a magazine comes there. All the ladies in that town get together. What is he going to divorce? Is he going to divorce? All those things. So. But no way you can predict. Episodes can go forever without a divorce, that kind of a thing. It is a fundamental, this is a mathematical framework. Halting theorem is a big problem in the computer science. It keep on coming sometimes, and then it spoils the whole party. So that is a fundamental limit in the so this is where humans beat AI 100 ways. This is the real science, neuroscience. Is the limits of AI intuition. Our intuition is so powerful. We are in the brain. It is already research done. Default neural network (DNN), pre-wired brain circuits. We can do perception. It's like a painting. Canva painting is already there, and then just to paint it. You already have the pre-wired brain circuits for perception, reflection, reflexes, and motor skills. All of them our brain is ready made for that. It is, if you take the computers, there is no ready made. You have to teach them all the fundamental training program you have to do, from the weights and the neural weights to all the way to transformer network. You have to build from scratch. You have to teach them how to recognize every ball. You can teach one ball, and then so tennis ball, you can say football. Humans can recognize very easily, but the computers, you have to train all of them again, one more, all the way. So that is a fundamental limit, because it is we have a head start. For the default neural networks or DNN is real. These are our brain. When you sleep, actually our brain works and do the computing. It does all the work. So default neural network intuition is so powerful for humans. The second was innate structure. The new research study showing, actually including Meta AI, what they found is our brain structure itself allows you the understanding of the physics. Somebody throws a ball, you catch it, even a 1-year-old kid. You don't need to learn all the Newtonian mechanics. You don't need to learn all the Albert Einstein stuff to understand the basic cause and effect. If you touch the fire, you get burned. These are all was done already. Structure is in place for that in the brain. So human brain has a very advanced at this time. Innate structure is not there. It has no built-in understanding physical world. That's a big problem even for the Tesla, because they try to do self-driving cars, because it is a big problem. Understanding the physical world is not easy. So you humans really excel in this area. That is where the doctors can do very well. Educated physician. So that is a default. Sorry about that.
And nurse.
Yeah. So what is the doctors can do? Default neural network, experience, context, and intuition. All of them they can use. Conflict. Dr. Patel was demonstrating now today with all the operation, the complexities involved in the open heart surgery, on the valve replacement. Innate structure allows you the potential risk. The AI cannot. I tell you that the AI has a restriction on certain restriction on the prediction. is a reducible computational complexity, they call it. Reducible computational complexity is it stops, you cannot determine the next step unless computation is done. So that's a problem. But human brain doesn't have that restriction. Asking the right questions. Prompt engineering is important. In physics, everybody says asking questions are the more important than answers sometimes. So treatments that explore unusual cultural effects and all these things, ethics and empathy. There was a research done recently. There are 10 kids. They asked them, peanut sandwich. The two kids in the out of the 10 kids have allergy for the peanuts. What the AI said that, yeah, quarantine the two kids, the 8 kids get the peanut butter. But when they interviewed, something stunning happened. All the kids, 8 kids, said that we don't want to eat. We want to sacrifice for those two kids. We don't want to eat peanut butter sandwich. That is a very human, very strange. We empathize with other people. That is AI is a long way to go. I'm not saying AI will not catch. So what is the future of the AI? But there is a power of AI you can use. These are the tools. The future physician is going to be like this: is a healer of body and mind, is a communicator. You have to be storytelling. The doctor has to tell us stories. Leader of a community. I met a lot of leader of doctors in the communities. Warrior for justice, poverty, iniquity, all of them. And friend, people who are older, people are lonely. That's one of the things you need to replace. How can you do all these things together? That's where the AI comes. These are the tools. Life coach, assistant, career paths, spiritual leader, empathy. When you're dying in hospices, you can be a philosopher. Talk about sickness and death. All of them. Now AI can give you power, the tools for you to talk with them. The future of a doctor is going to be this one. He can be Plato, like he is going to talk about how the universe works, and how the Plato talks about a philosophy. Mother Teresa's compassion, Hippocrates, morals and ethics. Gandhi's morals, empathy and kindness, and Jesus Christ, compassion is a very well demonstrated compassion of the leper touching, and Maya Angelou's poetry, storytelling, and Florence, Susan's area, Florence Nightingale, she was the bright star for all of us. She was a fighter. She was an aristocrat, fighter, leader, all of them. So Buddha, what is the nirvana, what is the life is all about. I think the future is going to be, the doctors are going to be this kind of a tools they have to use really to go against the AI invasion, in a sense that, but AI, you can use AI as a friend, as a tool. If you use it, these are all tools, then you can be all of them. That is the power of the AI is giving you. You can be all the tools in those people that all these famous people gave us, that the tools you use it, that is the healing. That is a epitome of that is a epitome of the physician and the morals of the physician. Thank you for listening. That's all I want to say. Let me
Ram-
take my French.
Yeah, Raman, I would end with one comment that my mentor, Barry Ketzen, he said that AI won't replace the doctors, but the doctors who are using AI would replace the doctors who are not using AI.
Yeah, correct. That's absolutely right. Because that's going to be the future. You have to use AI as the power of tool to communicate with the patient. There are so many things you have to do that
Yeah.
patients expect a lot more. As you know that if you do surgery and then go home, and then that is not enough. You want to communicate. You want a storyteller. You want to tell all your experiences and everything. That is sympathy and all those things. Susan, you tell me.
Well, I'm going to tell you that. Well, first of all, that was fantastic, because I think in there's so much going on in the world right now where there's a lot of fear and distrust of AI, and then when it comes to our world, I'm this, mine in nursing and Dr. Patel's and being doctors and nurses, I'm not afraid of all, because I know what my intuition is. That last slide that you just had up, those are what we do every day. I mean,
Yeah.
that we do storytell. We must relate to our patients. Their healing journey isn't all the medical devices that Dr. Patel has referred to throughout this entire. It's us human to human that through our hands and our minds and our brains, we are giving these extended lives, and they're allowing to walk upstairs and have families and continued years of life. So I personally have not been afraid. I can't wait for AI to take the tasks that slow myself, my nursing colleagues, and Dr. Patel down off of our back, so we can do more storytelling, really spend that time communicating, and spending more time with our patients and that we want to.
Yeah, I think, Susan, you rightly pointed out, this would allow doctors and nurses to be doctors and nurses. Because right now what's happening is a lot of administrative burden on the nurses and the doctors that occupies a lot of time. Like how many times the nurses are spending in terms of documenting this medication. I mean, yeah, we gave it. How there could be a camera up there which just notifies everything, and just the computer just notes down that, okay, yes, medicine's given, this medication's given. You don't have to type every single thing. And similarly, right now the physicians are burdened of writing notes, right, while they're evaluating the patients in the office. And majority of the complaint that the patient have is the doctors are not talking to them eye to eye while they're seeing them in the office, because they're typing in the computer. That's not what the patient wants. They want somebody who's talking to them, seeing eye to eye, holding their hands if they're uncomfortable or vulnerable, showing them compassion, kindness. And I think, there are some tools coming out like AI scribes and things like that, where the doctors don't have to spend, time doing all those, the work which takes them away from the patient.
So what I presented is actually scientific. I didn't do anything. It's not abstract. It's not some kind of there. These are all mathematical and scientific way that you cannot be replaced. The humans, you have to. I'm not saying it's not going to be done. It may be in the future. It may be a long way from here. But at this time, there is nothing that you can replace a physician at this time. No way.
Yeah.
And again, there will be plenty of areas where that's welcome. I mean, there's plenty of areas where that's welcome. And then ultimately, I'm going to circle back to I'm not afraid of it myself, only because I see what Dr. Patel does on the daily and what he's just done. Traveling over to Ethiopia and doing hundreds of procedures on. There's not, AI is going to be slower adapted over there, and here you are, human to human, with a team of 30 plus volunteers, heart to heart, human to human. You can't replace that. Like you said, maybe years and years and years to come, but I think that most of us are in it to win it with that human connection, and we are at the center. Our hearts are at the center for sure.
Yeah.
Dr. Patel, you sacrificed your time to go to Ethiopia. Just tell us a little bit of experience of that Ethiopian experience, if you don't mind, before closing our
Yeah,
talk.
sure. So Ethiopia, my friend, Tesfaye Talila, he's an Ethiopian interventional cardiologist. He practices in Piedmont system, and he founded a nonprofit organization to improve the heart care or the cardiovascular care in Ethiopia, because Ethiopia is population of Ethiopia is 120 million, but the number of the cardiologists are probably less than 50 in the whole country. There's only 7 cath lab in the country. Here each hospital might have 7 cath lab, right? And that was the reason he started this organization about 2 years ago. He asked me to join him. That's what led me to join. And initially our goal was to treat about 120 patients. There was no plan for doing a valve replacement, but he said, why not do a valve replacement? He might have tried in the past, but somehow couldn't get it completed. So we actually approached different companies, and Abbott actually gave us 10 valves, 10 transcatheter heart valve, and we did the valve replacement in a country where even the STEMI network is not fully established. That was also another major experience, in the sense that how we did that valve replacement is, here we have multiple folks, a big team, and there we were actually creating a team on the fly. So usually you need a CAT scan, as I outlined. So they had one CAT scan which does gated CT, and that cardiologist allowed us to use that CT. So they all the patients which we asked them, all the cardiologists, that okay, we're going to be able to do the TAVR procedure also. Just about 10 days before we had the mission trip started, and they were actually collecting the list of the patients who have this issue, severe aortic stenosis. They started calling all those patients. Majority of them actually died while waiting. As I mentioned, a mortality rate is 50% at 2 years. So there are a lot of patients who died, but those who are still alive, they called them to get the CAT scan at that particular CT scanner in Ethiopia, in Addis Ababa. They got the CT, then they sent the CT through Google Drive to an imaging expert in Piedmont, Atlanta. They did the analysis, the virtual CT analysis and things like that. We reviewed the whole report, all the images, and me, Dr. Jim Cowton, the surgeon, we sort of confirm which sizes we're going to be doing, what's going to be the plan, and then we implemented that plan in that government hospital with nurse-led sedation. The nurses actually gave the sedation over there, and this is the first time we're doing it in that country. And all the 6 patients that we did, they all went home the next day.
It's just so cool.
Thank
That's
you.
so cool.
Along with that, we actually did almost 100, cardiac catheterization, stent placement, valvuloplasty, 30 ablations, pacemaker defibrillator by Dr. Goyal, then 16 adult surgeries by Dr. Jim Cowton, and 10 surgeries by Dr. Maharaj from Canada, pediatric surgery, and another 10 surgery by one of the surgeon who came from Bangalore, from Narayana Health. And that's how we sort of completed all those procedures.
So what now, AI? What now? Come on. That is the most human experience gift, period. So
Dr. Patel, the show is coming to the end. Thank you. It is an honor and privilege. I'm so impressed by your knowledge and your compassion for helping people. I think we need more doctors like you in this world, and I think there is no way can replace people like you in this.
Not a chance.
Nobody. Thank you for so much coming. Thank you, Susan, as usual.
Thank you.
Thank you so much.
Thank you, Susan.
Pleasure.
Thank you so much, sir. Thank you so much for the.
Super cool.
It's a truly honor.
Bye.
We are retelling their stories through our patented designs that can be worn on scrubs, t-shirts, printed on conference bags, and endless other promotional materials. Daily Wear for Medicine is the first ever of its kind to create curiosity in medicine through visual art. We at MedBricks are celebrating unsung heroes of the past who made enormous contributions to the field of medicine through our unique campaign called Daily Wear for Medicine. You can wear it, carry it, and give it.